All right, good afternoon. Thank you so much to Stephanie, Charlotte, and Wendell. Like I mentioned earlier today, I've been with the Alliance for Health Policy for 10 years, and I've been happy to work with Wendell for many of those, for many of our summits and symposiums, so always good to have him back. It is now my pleasure to welcome our fourth and final panel to the stage, Administration Outlook, Health Policy Priorities in 2026. I'm thrilled to introduce our final moderator, Claire Sheahan, the President and CEO of the Alliance for Health Policy. Claire is a dynamic executive with more than 25 years of experience effectively engaging others to catalyze change in healthcare and health policy. Claire has served in leadership roles in associations, corporations, consulting, and communications firms, including GMMB, the Blue Cross Blue Shield Association, Fleischmann Hillard, the Generic Pharmaceutical Association, now AAM, Avalier, Alexion Pharmaceuticals, and others. She has led programs for a variety of nonprofit organizations, including the American Society of Hematology, the Bill and Melinda Gates Foundation, the Robert Wood Johnson Foundation, Mayo Clinic, and others. Claire is a graduate of the University of Illinois at Champaign-Urbana and also holds a Master's of Science with distinction from the London School of Economics in Media and Communications. Joining Claire on stage, we have Brian Blase and Liz Fowler. Brian Blase is the president of the Paragon Health Institute. Brian was special assistant to the president for economic policy at the White House's National Economic Council from 2017 to 2019, where he coordinated the development and execution of numerous health policies and advised the president, NEC director, and senior officials. Brian worked for both the House and Senate, guiding the House Committee on Oversight and Government Reform's Healthcare and Entitlement Program, oversight and investigation efforts from 2011 to 2014, and then serving as the Senate Republican Policy Committee's health policy analyst from 2014 to 2015. Brian received his Ph.D. in economics from George Mason University. Liz Fowler is currently a managing partner at Health Transformation Strategies. Liz is a nationally recognized expert in federal health policy and a distinguished scholar at the Johns Hopkins Bloomberg School of Public Health and the Carey Business School. Liz brings more than 25 years of experience advancing healthcare reform and innovation across government, industry, and philanthropy. Most recently, Liz was Deputy Administrator and Director of the Innovation Center at the Centers for Medicare and Medicaid Services, leading national efforts to accelerate value-based care. Liz previously held senior roles at the Commonwealth Fund, Johnson & Johnson, the White House National Economic Council, where she helped implement the Affordable Care Act. As Chief Health Counsel to the Senate Finance Committee, she was principal architect of the ACA and contributed to the 2003 Medicare Modernization Act. Liz holds a Ph.D. in health policy from Johns Hopkins University, a J.D. from the University of Minnesota, and a B.A. from the University of Pennsylvania. Claire, Liz, Brian, the stage is yours.
Kelly, can you advance the slide?
Yes, I can.
Thank you.
Should have done that first.
Great. Well, thank you so much, Kelly. And thank you, Brian and Liz, for joining me this afternoon. You all probably weren't here when I talked about the fact this is one of our most popular events. You can see the room is very full for this conversation. So I'm looking forward to talking about what we expect for the administration. So I think those were kind of long bios, but I think it's worthwhile to understand a little bit about where everyone's coming from. I think we just saw a real-time discovery that these two had the same job at one point. And so I think, that context is important as we think about the conversation we have today. So I'm going to get us started. The last panel talked a little bit about Congress. Today we're here to talk about the administration. Before we start looking forward, let's think about this year, which was an eventful one. Not every year is a year where we're talking about health policy every single day in the, sort of public sphere. And this year really was one. So I'll start with you, Brian. What do you think were the highest impact actions of the administration in 2025? And what might those downstream outcomes be in a couple of years?
Yeah, thank you, Claire, and great to be with you, Liz. So the first year of a president's term is generally action-packed. And often, if the president has majorities in both houses of Congress, they use reconciliation. And the big legislative achievement of the Trump administration was the One Big Beautiful Bill, and it included significant health care provisions The Medicaid reforms, I mean, it is the most important Medicaid reform, arguably, that we've ever had from a conservative perspective. The policies that I'm most excited about are the ones that right-size or that help right-size the federal-state partnership, which had really gone off track with state financing gimmicks and schemes. The provisions to reduce what we refer to as legalized Medicaid money laundering, to limit states' ability to engage in provider taxes and really limit the amount of corporate welfare that has infected the Medicaid program and has allowed many hospital systems to generate pretty massive profits off of the way that the Medicaid program works with these state-directed payments. Also, the provisions to implement community engagement requirements in the program. I think it's a sensible policy, given that the federal government is reimbursing so much more state spending for able-bodied working-age adults than they are for traditional enrollees. It's 7 times a greater reimbursement to aim to protect the Medicaid program for the truly vulnerable, and then to take some reforms around the ACA and program integrity and limit a lot of the enrollment abuses that have led to some significant fraud in the program. That is just a major set of wins for the president and for the congressional majorities. I think a big issue going forward is how these policies are implemented. It's going to revolve to some extent on what happens at the state level. So there's a role for effective state implementation of the key Medicaid provisions within the Act, as well as combating a lot of special interest pushback. I mean, the provisions that restricted Medicaid spending were not health insurers, hospital systems were not fans of those provisions. They're looking to roll some of them back, and I think being able to defend them and the importance of them is a priority for the administration and Republicans going forward.
So the second part of the question then is, in 3 to 5 years, what's going to be different, right? Understanding implementation is not a known. What do you think the 3 to 5 year impact might be of some of those provisions?
Well, the work and community engagement requirements take effect in the beginning of 2027. So we'll see how effective they are at encouraging work among able-bodied Medicaid enrollees and hopefully reducing enrollment in the program and encouraging enrollment in private insurance. And then I do think the big change is on the financing side and whether these restrictions to the gimmicks that states have employed. And there's been bipartisan concern about these gimmicks. I mean, Joe Biden, when he was vice president, called provider taxes scams and said that they should be eliminated. And it was actually President Obama's budget proposal to reduce provider taxes that is the exact proposal that was in the House or in the One Big Beautiful Bill. These restrictions on payments to Medicare rates, which I think are entirely appropriate. I think Medicaid paying up to average commercial rates is ludicrous. Average commercial rates are 2.5 times Medicare. It's excessive profits that have been made through the Medicaid program. I mean, do those things actually take effect? If they take effect, I think they're going to create a more efficient health system.
Great. Liz, what are your thoughts on what was the biggest impact and what those downstream outcomes might be?
Sure. Well, first, thanks. It's nice to be here on stage with you, and I appreciate the opportunity. I do agree that OB3 or HR1, I don't generally call it the beautiful bill, but appreciate that perspective. I think that is really the most significant accomplishment. But, you know, I guess I view it through a very different lens. I think it is the biggest rollback of the Medicaid program in 60 years, in its 60-year history. It is combined with the ACA failure to extend the subsidies could lead to 10 to 15 million people without coverage. And I think it's a very significant impact that's going to reverberate across the healthcare system. And it really does unravel a lot of the Affordable Care Act provisions. And I think more importantly, it's an indication of the policy priority that healthcare must be earned, that there's a notion that you have to earn the right to healthcare coverage. It's not something that's granted, and that you have to be deserving of coverage. And I think that's a very different philosophy than what ACA tried to do, which was to expand coverage. And so I think the impacts of that will be felt. I agree that we're all going to be watching the implementation to see how much flexibility perhaps states have or don't have. I don't disagree that there was probably a need to start looking at some of the provider tax approaches, but I think the impact, though, is going to be really felt by a lot of people. And I also feel like it is sort of counter to making America healthy again. If we want to make America healthy again, I think it starts with being able to access coverage, prevention, and be able to see your doctor when you're sick, to have affordable coverage and affordable care when you need it. And I think we have seen a rolling back that is really significant. I do also want to talk about, I think, watching the other sort of major area is on drug pricing. And you've seen the administration pull out every tool in its arsenal to try to address high drug prices. And I think it's really significant, including administrative actions, the Innovation Center tools to try to look at ways of scaling back pricing. You've seen sort of bringing all the CEOs to the table and sort of a little arm twisting here and there. And so I think it's been really interesting to watch the whole process. I give them a lot of credit for sort of pulling out all the stops. I think the 3 to 5 year impact, we will see if that has had an actual impact on people's out-of-pocket costs. But that's the other area that I would mention.
And that's what you'd be watching, is the out-of-pocket cost, right? Because there's a lot of different indicators there.
Exactly.
That makes sense. So, and almost a counter to that first question is like, those are areas where you see the world very differently, right? Are there areas of bipartisan opportunity that either of you see going forward?
Do you want to start? Or you want me to?
Sure. I mean, I think one of the events that Paragon had last year, where I moderated a discussion with former Secretaries Sebelius and Azar, was on site-neutral payments in the Medicare program. I think there is an acknowledgement that the government does have payment systems that create distortions that don't make any sense and that raise costs, both for taxpayers, for seniors as well, but also for commercial payers. So much of what commercial insurers do is link their payments to what Medicare is doing. So if Medicare is paying more for the exact same service in a hospital than could be provided in a doctor's office, that just goes throughout the broader healthcare system and puts incentives in place for consolidation. And I think we've seen a tremendous amount of consolidation, hospitals buying up physician practices. One of the, I think, very much agreed upon health economics points is that consolidation increases prices, and we've had significant consolidation. So I think site-neutral payments in Medicare is one, and I think another one is Medicare Advantage reform. Paragon, we put out a paper a year and a half ago where I think we recognize Medicare Advantage has a lot of benefits. Seniors value Medicare Advantage and the supplemental benefits from Medicare Advantage. But I don't think the Medicare Advantage program should cost taxpayers more than traditional Medicare. So there are inefficiencies with the way Medicare Advantage is constructed, and I think some attention to reforming the benchmarks, looking at obviously the risk adjustment and the problem of coding intensity, and that there could be some bipartisan work on improving the Medicare program overall by improving Medicare Advantage.
Liz, how about you?
Yeah, I agree. And first of all, I'm an optimist. There's always areas to find common ground. So behavioral health, rural health, strong foundation of primary care. I think Medicare Advantage is definitely one. In fact, all of what you said, I agree with. There's a need to go back and look at the program and make sure it's delivering on the promises that we think it should. I think one other area I might point out, because it's on the table now, is really trying to give plans the ability to offer healthy foods through Medicare Advantage, through supplemental benefits. Right now, there's administrative hurdles to being able to do that. So plans can offer kayaks and ski tickets, but they cannot provide healthy food. The MAHA caucus has written a letter to CMS asking for that flexibility, and it's something easy and something that the administration could do this fall in their rulemaking. But I think all of the areas that Brian mentioned are definitely on our mind as well.
So there are areas of bipartisanship, because I get that question a lot, right? Like, does such a thing exist anymore, right?
You have to be willing to reach up and grab it, but yes.
And there are areas where it is taking on the industry and special interests. You're going to get enormous pushback if you try to do site-neutral payments from the hospital lobby. And so I think these are issues where policy right now is very constructed to benefit powerful industry, and it is very hard to change policy because of the political power that the industry has.
But I want to say something that I think the administration deserves a lot of credit, because, and I've said this in public and private forums, they're really not feeling beholden to a lot of those interests, and they're not afraid to break eggs, and they're not afraid to sort of challenge the status quo. And I think that's a really important feature. And you can get a lot done. There are a lot of things about our healthcare system that are broken. And so I think if we decide to sit down together and tackle those areas together, I think I'm really in favor of a lot of things that they've put on the table. So some of the changes they made in the physician payment rule, for example, to really rebalance the payments across primary care versus specialty care, I think has been really important. So we should celebrate some of those victories, while we, of course, express concern about the loss of coverage on the Medicaid side.
Yeah. And I think that represents a little bit of a shift, right? Like, there's a boldness that we haven't seen in other administrations
I appreciate
to
that.
look at the status quo. I would love to know, and maybe we'll start with Liz this time. We've just ended our government shutdown, as everyone in this audience is very aware. I think some of the folks, that were coming in were very happy that their flights, that people are back to work. So I'm wondering, Liz, if you think about this, how do you think there might have some impact, for the remainder of the year, or, what might those downstream outcomes be?
I mean, I think the shutdown, it slows momentum. They had a momentum going, and I think, you have to stop and think about getting the payment rules out, getting the announcements out. It stifles your ability to continue doing the work that you were doing. And so I think there has been a little bit of a slowing of the momentum. I think they'll pick right back up, but, that's a month, where they weren't able to do that. I think longer term, that sort of instability makes it really difficult for the rest of the industry to start thinking long term and make investments. It feels like it's the stability, the sort of predictability of what's going to happen, I think is undermined. I also think that these shutdowns lead to, sort of proposals on the fly to try to come up with, the shutdown in this case is about healthcare at its root. And I think I get that there's a reluctance to continue the enhanced payments, but I think the proposals that are coming out in response, I'm not sure are going to fix the problem, and I'm not sure are getting at the root cause of what ails us, which is what ails our entire healthcare system, which is that we have a problem on the cost side, and we need to tackle it across the board and not just looking at one target, which is the ACA, and saying we're not going to do that, because I very much fear that it's going to, whatever comes out of this discussion will, I think, have a very negative consequence on people and their ability to afford premiums.
So do you agree on the momentum, Brian? Is that one of the outcomes, or?
I have not thought about it like that we've lost momentum. I think the administration has continued to go pretty full speed ahead. I mean, they finalized the physician payment rule, and they've got other payment rules. And I think the provisions of the Medicare payment rules are really important. They do advance like site neutral payment policies. So they would, for one thing, they would get rid of the inpatient only list, and they would also expand the services that ambulatory surgical centers can provide. I mean, I think the clear focus now is the expanded subsidies in the ACA that were enacted at the start of the pandemic. And I think it has led to a very useful conversation about real problems with the program that have increased premiums, deductibles, and just exploded costs. I'm testifying tomorrow. One of the examples that I'm going to give is a family with 3 children in Prescott, Arizona. Their premium for a plan next year is $52,000. That is not a result from a well-functioning program. Like, there needs to be significant reform to the ACA, and the way that you avoid reform to anything is just to continue to send more taxpayer dollars at the underlying structure. So I think we have a moment to actually think about what are significant reforms, and there's reforms that are needed to the regulatory structure. There's also reforms that are needed to the subsidy structure. We have, and I think the ACA is inherently different than like employer-sponsored insurance because the subsidies, and I think we need to reform tax treatment of employer-sponsored insurance too. But the subsidy structure of the ACA is inherently inflationary. The entire cost of the premium over time is picked up by the taxpayer. Well, when you allow insurers to price knowing that the entire premium is picked up by the taxpayer, they don't price particularly well. And I think that's one of the reasons we've seen escalating premiums. And I would love there to be a real conversation that acknowledges the flaws in the ACA, and we want to have an individual market for health insurance that is robust. I mean, one of the policies that I worked on in the administration would allow employers to offer workers a contribution that they take to buy a plan in the individual market. I think it doesn't make a lot of sense for employers to choose our health insurance. It's a major financial product for people. Why do our employers select that one financial product? But if we don't have a good individual market, we're just going to be stuck with just so many inefficiencies with our programs that are mostly the result of perverse government policies that lead to just continuing escalation of costs.
So did I hear you say that the shutdown, that was part, like that there's a relationship between what was happening with the shutdown and the fact that we're now having these more in-depth conversations?
Well, the demand that the Senate Democrats had was to, well, there were different demands, but I think the one that had the most agreement was to extend the enhanced subsidies. So that has concentrated the political and policy discussion on this issue.
Well, I guess I would just say in response that Democrats raised these issues at the beginning of the year and said, hello, these expanded credits are going to expire. We should have a conversation about it. I mean, I understand the president's priority was really focused on the Medicaid, but nobody was willing to have that conversation until we come to this point at the very end of the year. And then I think people realized, oh, they expire and it actually will have a real impact on people. So I'm not sure it's a fair characterization to say they haven't been wanting to have a conversation. I mean, I think, and by the way, I agree that we need to look at the employer system. Senate Finance Committee during ACA tried to cap the exclusion by the single largest tax expenditure in the U.S. tax code is for employer-sponsored health coverage. And so we tried to cap that. We're not successful, but I think that's a conversation worth having. Also inflationary.
We were successful in capping it at the time.
Well, no, it didn't cap. Well, that was a tax. It was turned into a tax on insurers, which was
It was a way to deal with it.
That is not what we had proposed. We had proposed looking at the individuals. Anyways, so it didn't happen. It's not there. Agree, we need to look at it, but this should be part of a conversation. And I think what Democrats are saying is give it a 1 year and then let's have this conversation and let's have it across the board because we do have a cost problem in this country. No other country in the world spends as much on their healthcare system as the U.S. It's a very complicated, complex system for a lot of different reasons. We have the system we have because of the incentives we have and because it's very fractured. in any event, I think there's a conversation worth having, but I think waiting until the very end and then sort of we're all playing, like looking each other in the eye to see who blinks first, I think is not the way that good health policy is made. It took a long time, many, many months to do the ACA, to work on it, to refine it. Is it perfect? No. And part of that is the way that it passed, but it's been an important lifeline for a lot of people. And I think seeing these premiums go up and the potential impact it has is really, it's very jarring to hear some of the stories. And I agree, nobody should be paying that much for healthcare. But this gets back to, do we think that healthcare is a right, or is it something that is earned and a privilege? And if we think it's something that should be available to everybody so that we stay healthy and maintain health and all the things that we want, that at least the good parts of the MAHA movement in my mind, then we should have a conversation about that, because I do, in my optimistic days, think that there is common ground to be had if we sit down and try to talk about it.
So we've talked a lot about cost and affordability, and that's very much on the minds of, I think, everyone looking at healthcare right now. With that in mind, what do you think in the coming year is most important for the administration to focus on? I'll start with Brian this time.
Affordability. So, I mean, it's going to be affordability, and they're going to be, they're going to be focused on effective implementation of the One Big Beautiful Bill. I agree with Liz. The president, the number one healthcare issue that he is interested in is drug pricing, and the fact that Americans pay so much more for the same drugs that people in other developed countries pay, and what leverage and tools they have, whether that is through trade, whether that is through thinking through what CMMI models could be. But I see that they're going to continue to try to build momentum and reach more agreements with pharmaceutical manufacturers. And then this issue of affordability and what's going to happen with the ACA. The president has provided his direction where we need to think about subsidizing individuals and patients instead of just sending all the money to health insurance companies. I'm very supportive of that policy direction. I think that there are ways that we can reform government programs by reorienting a portion of the huge amount that we subsidize health insurance and health care in this country, to give patients the ability to control that.
I mean, I guess, first of all, I'm not sure how you operationalize that. I don't know how you, in the next month, figure out how to give money to people directly, and is that going to translate into making premiums more affordable for the people that need them, or is it supposed to be not going to premiums and instead going to tax approaches, FSAs or HSAs, which some people may not have or be able to use? We're all going to get eyeglasses at the end of the year from if we're giving it to FSAs. I mean, I don't understand how you would operationalize that in such a short period of time, which is why the easiest option is let's agree on a truce and figure out, and then spend the next year thinking about how to make coverage more affordable. And to the point that
a truce can't be just extending the subsidies as is.
But we waited
till
the last minute. It's like
Yeah,
we
but
waited until our homework was due and our test is the next day, and now we don't have any choice. I don't see how giving money to people at this, I don't know how CMS would do that. I don't know how the administration, I don't know how they would do that.
Well, I think standing up a program like that would take there'd be some implementation to it. I mean, we developed an HSA option, which would, and this is getting probably more into the weeds than we want to, but fund the cost sharing reduction program, which is a second subsidy program in the ACA that lowers deductibles and out-of-pocket payments. The Obama administration is making illegal payments to insurers because there wasn't a valid appropriation. So the Trump administration stopped making those payments, which led to significantly higher premiums in the exchanges, something called silver loading. You could do a CSR appropriation, you could lower premiums, and you could give individuals the option to take that subsidy payment that goes to the insurers for insurers to reduce deductibles and co-payments and allow individuals to take that as a contribution to their HSA. So that's one, working within the ACA infrastructure, actually going back to sort of the original design of the ACA, which didn't have these silver loaded premiums, where you could implement the policy consistent with the president's vision.
I think if we were to close the doors and say, okay, this is what didn't work, here's all the things that we didn't really like, unintended consequences, maybe sometimes intended consequences, that would be one thing. But the problem is, checks watch, it's November 18th, and these premiums go up January 1st, and I don't know how it's going to be possible to do all of this. Having worked on the inside and the administration, on the implementation side, I just think CMS, maybe it goes through just the Treasury, but it just feels like a lot. And I just want to make one other point of we do pay more for drugs than any other country in the world. We also pay more for healthcare than any other country in the world. So I think there's a larger conversation to be had than just looking and I appreciate that we're looking and comparing to what other countries are paying, but I think there's also so many other conversations we could have about how not affordable our healthcare is and what that does to people's out of pocket and their ability to afford basic standard healthcare. And I think there's a whole conversation that we could have, but in the short term, I don't see how we get out of this boat except for taking the easy road or just foregoing it altogether, which would be a disaster.
So taking it from implementation, hearing you on implementation is hard and it takes time, right? That's what I'm hearing you say. I think let's take a step back from the sort of getting our hands dirty, thinking about the implementation, and now think ahead to say, all right, what are our goals, right? If we were to have a dashboard, say, for the year or the next several years, what goals should we be measuring progress against? Obviously you two have very different ideas of what policy should achieve. And I think when we talk about the implementation and we get into the details, there's a lot to understand there. There's also a lot to understand about what are we trying to achieve? What is the end game here? And I think those are two very different perspectives. And I would love to hear, I'll start with Liz this time, what goes on your dashboard when you're thinking about, how do we think about good health policy, right? I think people talk about good health policy as if that's a shared set of metrics. And I actually, in my experience, it's very different. So I'd love to know what goes on your dashboard.
I'm guessing that a lot of it's going to be the same because I think at some level there is agreement here. I think I want to know, is coverage affordable? Is care affordable? Can people go see their doctors? Do they have access? And then some metric of outcomes and quality. Are we providing, do people live longer? Do people stay out of the hospital? Are they able to see their doctor? Can we avoid bankruptcy from healthcare? All of those things. And then turn to some of the administrative burdens. Our system is incredibly burdensome for a number of different reasons. Again, if we got behind that closed door, I'm sure that we could come up with some ways to reduce that administrative burden. Do providers, do they want to practice medicine? Do they want to provide care? A lot of them are really burned out, and I think that's also should be on the dashboard. So I think there's a number of issues that I find that would be common that we could come up with on a dashboard.
How about you, Brian?
I mean, we want to get better health and spend less money on healthcare. So what are our health metrics? I mean, life expectancy is probably the easiest, the best metric. But other measures of health, I am deeply concerned about the $38 trillion federal debt. And what that means in lower American standard of living over time. There is one area of the federal government outside of interest payments that are growing as a portion of the economy, and it's federal health care programs. They are on an unsustainable trajectory, and one of the measures that I have for success is, are we moving programs and putting them on a more sustainable trajectory, so we're not leading to the bankrupting future generations of Americans and the much lower standard of living that will come from massive federal debt, inflation, and interest rates.
Makes sense. Some similarities and differences. What did you have a thought on?
Oh, I was just going to say, but the debt is a function of money coming in as well as money going out, and you have to look at sort of both sides of the equation, and you can't just look at the money going out and saying we have a cost problem. We also have to look at a revenue side, just from the Senate Finance
I don't
Committee.
disagree that there's two sides of it, but the overwhelming issue on the spending side are federal health entitlement programs. And President Obama made this statement when he was, advocating the ACA, is that we need to get control of Medicare and Medicaid. There have been some improvements on Medicare, but Medicaid spending is off the charts, and ACA spending, particularly with these enhanced subsidies, is now off the charts.
So I think if you had asked me if Brian was going to quote Biden and Obama quite so much, I probably wouldn't have. I wasn't ready for that. You're a little shocked over here.
It was very effective in being able. It's very effective in being able to advance Medicaid reforms when I could show a slide with President Biden and what he said about provider taxes, and then quote from the Obama budget and say, this is what you should do. Do what Obama wanted to do on Medicaid reform. And that is what they did on addressing the provider taxes. It was from the Obama 2012 budget.
Can I get credit for I want to make America healthy again, too?
Yes, that's right. Well, yes. I was
like,
also going to say, yes, I love that, Liz. And I also think, you have a lot of the similar things on your dashboards. And I think it's also important that we ground our conversations in where are we going? Like, what are we trying to achieve? Because I think sometimes when we leave that outside of the conversation and we get into the technical really quickly, those disagreements are actually showing, that those areas are different at the root. And so if you can have that conversation first, you can have more constructive conversations on the technical side. So we are going to end this on a high note and wondering, where do you see the greatest opportunities in 2026 for the administration? If it was up to you, what do you think the best opportunities are going forward?
What do I think are the best opportunities in 2026? For health care generally, I think there's a lot of promise in GLP-1s. And the administration is taking some actions to try to reduce the price of GLP-1s, but I think we're getting a lot of evidence of the benefits of GLP-1s, and it could be really helpful for people that struggle with obesity. I think there are complicated issues of how Medicare handles paying for GLP-1s, and I was not a fan of the Biden administration rule that was just going to allow Medicare to pay for GLP-1s, and when it's going to have significant budgetary costs. I don't think the government should be doing anything that increases Medicare spending overall, but I like the approach that the Trump administration has of paying for that coverage expansion. And then I really do think it's the affordability agenda. It's the affordability agenda not just on healthcare, but across the board. And I am excited about doing work next year on really evaluating the aspects of government programs, and we've talked about several of them, that make healthcare less affordable, including the taxpayer share. When I think about affordability, I'm thinking what's the enrollee pay, but also what is the taxpayer paying, because what we want to do is make the system more affordable for both enrollees and taxpayers.
Well, sign me up for the affordability conversation.
Okay.
I would love to be part of that, and I think value-based care is an important component of that. I also, in terms, you asked, is there something that's exciting? I am really excited to see what states are proposing under the Rural Health Transformation grants. I think there's the opportunity to think really creatively about how to make sure we have access in rural areas, and I think there's a lot of money on the table and a lot of, hopefully, creative thinking. I think the fear is that states are going to have so much on their plates to try to implement all of the changes from OB3 that they're not going to have enough time and attention and effort to be able to pay towards those potentially really creative ideas. But I'm hoping that they can do both. And also in the implementation, I hope there's enough flexibility that we can maintain as much coverage as possible given the cards that were dealt.
Makes sense. So is there anything we didn't cover that you either one of you wanted to cover today?
What would you like to talk about for the next?
I don't know. It's like 3 minutes. I feel like we covered a lot of ground.
Yeah.
A lot of potential agreement if people were willing to sit down and have those conversations.
Are there any surprises that either of you had in this conversation? Anything that you didn't expect?
Well, I've read a lot of Brian's stuff. A lot of creative ideas. I think there is a lot of possibility in looking at sort of the employer space of thinking about affordability of some of the Medicare Advantage issues. So I think there's common ground to be had.
Everything is exactly as you expected, Brian.
I appreciate. I mean, I think there is fair amount of agreement that things are unaffordable, and I think the comments on drug pricing are very aligned. I think about it, health policy as an economist, and you look at the incentives within government programs and how can we align incentives to improve the value that we get, but also we allocate so much in health policy through the political system rather than through the market system. So it is not, what we want is providers that are best serving patients and that can make profits. Like, I don't have any problems with profits. Providers, insurers making profits, providing care, innovating, providing financial products for funding healthcare that people value, rather than just maximizing payments off of government reimbursement formulas and coming to Washington to lobby CMS to make sure that their thing is covered and to increase the payment rate and to protect them from competition. So I think fundamentally, if we want more affordability, we need to reduce the role of politics and reduce the role of government in allocating all of the resources, and we need to allow sort of an abundance agenda where we really, because I don't talk about healthcare in terms of the rights language that Liz talks about, but I want everyone to have access to high quality, affordable coverage, and I think that is going to be best achieved if we really think about freeing people to buy what works best for them, and then freeing providers, insurers, drug developers to create products that appeal to the patient.
Right. Well, I think, again, I am surprised by, there may be different ways of getting there for sure. And there was lively conversation and different ideas proposed. But I think I am surprised at how much agreement there is, at least in the goals. And I think that's a learning I will take away today. So thank you both for joining us. I am going to walk over to the dais now, but I would like to just thank all of you, because I have a two-parter here.
Is this what we're supposed to do?
Yes, so we're going to applaud for our panelists. Thank you both, our panelists.